Hello, my name is Lindsay Arick. I'm a consultant anaesthetist at University Hospitals Plymouth, and I'm going to discuss some basic principles of neuroanaesthesia in the context of craniotomy for tumours and the evaluation and management of brain relaxation. We will cover the principles and anaesthetic goals of craniotomy for tumour resection. Alongside this, some applied neurophysiology and pharmacology. And finally, I'll cover the differences between brain relaxation and intracranial pressure and how these are evaluated and managed. This topic is important and relevant because craniotomy for tumour resection under general anaesthesia forms the bulk of our intracranial work. We will just be considering supratentorial, so anterior and middle fossa tumours requiring general anaesthesia. There are some important differences and nuances with posterior fossa surgery, with endoscopic surgery, and also with awake craniotomy surgery, which can be covered in other sessions. So what are our anaesthetic goals? The broad goals of neuroanaesthesia are firstly to provide tight control of the physiology so that cerebral blood flow and cerebral oxygenation are preserved. This is often in the context of a vulnerable brain. This needs to happen throughout the whole procedure, but clearly induction of general anaesthesia, stimulating parts of the positioning and surgery, and extubation are potentially the most dynamic times which need a particular attention to detail. To do this well, there needs to be an understanding and anticipation of the surgical steps. Secondly, we need to provide optimum operating conditions for the surgery to progress. And this is where brain relaxation needs to be considered, as well as having an adequately anaesthetised and still patient. Thirdly, we need to enable a rapid return to consciousness to enable neurological assessment. This is also whilst maintaining that stable physiology and preventing any blood pressure swings or any coughing or straining which may contribute to early bleeding. There's clearly a range of combination of drugs and kit and equipment with which these goals can be achieved, but I'll run through a fairly standard approach. Before we start, it's worth having a very quick review of the relevant physiology and pharmacology. So the brain has a very high energy and oxygen requirement. Cerebral blood flow is a high percentage of resting cardiac output. A normal average flow in an adult is about 50 mils per 100 grams per minute. There's very limited capacity for anaerobic metabolism, so maintaining this level of flow is critically important for brain function and viability. Cerebral blood flow is determined by cerebral perfusion pressure, CPP, and cerebrovascular resistance, CVR. Cerebral perfusion pressure is in turn determined by the mean arterial pressure and ICP and central venous pressure. So a number of important mechanisms act to maintain cerebral blood flow across a range of physiological conditions, and these act by altering the vascular resistance, so by changing the calibre of the vessels. Firstly, autoregulation. This is a global physiological process by which cerebral circulation adjusts its resistance with changing systolic blood pressure to maintain a constant blood flow. The normal autoregulatory range is generally regarded to be from mean arterial pressures of 50 to 150 millimetres of mercury. You can see here on the blue line on the chart. This is an almost instant process occurring within 1 to 10 seconds of a change in pressure. It's thought to be mediated primarily by an endothelium-derived relaxing factor and by nitric oxide. Above and below the autoregulatory plateau, cerebral blood flow becomes pressure dependent and directly changes with changes in mean arterial pressure. So at higher mean pressures above 150, cerebral vessels are open up, become dilated, and blood flow increases. At low mean arterial pressures below that autoregulatory plateau, blood flow reduces and the vessels become slack. In chronic hypertension, there is a right shift of this plateau. So in these chronically hypertensive patients, cerebral hypoperfusion will occur at higher values of MAP compared with healthy individuals. And the limits of autoregulation are also probably affected by other factors such as sympathetic nervous activity, PaCO2, and drugs which can blunt autoregulation. The second mechanism is metabolic factors. So CO2 and O2 partial pressures can also globally influence cerebral blood flow. Starting with CO2, the green line on the graph, there's a linear relationship between a PaCO2 of 2.7 and 10.5, changing 10 to 15 mils per 100 grams of tissue per minute for each 1 kilopascal change in PaCO2. There is maximal vasodilatation at that upper end, so a PaCO2 of 10.5, where blood flow is nearly doubled. It's maximal vasoconstriction at 2.7, and at this level, cerebral ischemia is a possibility because of that vasoconstriction. Response to CO2 is also very rapid, occurs within a minute and plateaus at 12 minutes. So decreasing the PaCO2 from 5.3 to 2.7, from that top end to that bottom end, will decrease the whole brain blood volume by 10 to 14 mils almost immediately, but at the risk of causing cerebral ischemia. So O2, demonstrated by the orange line on the graph, shows that above a PaO2 of 6.7, there's limited change in cerebral blood flow. But at this inflection point, at lower values of PaCO2, vasodilatation occurs and cerebral blood flow increases. So locally, cerebral blood flow and metabolic demand are coupled by flow-metabolic coupling. It's that third mechanism. This is where local blood flow is changed in relation to the cerebral metabolic rate. So a method of matching oxygen or glucose delivery to requirements. Metabolic activity is highly variable across different parts of the brain when different parts are being used, largely dependent on neuronal activity, and needs are matched with supply. This happens within seconds, and many chemical mediators are likely involved. The fourth mechanism is neurogenic control. So the cerebral vasculature has sympathetic and parasympathetic input, and excessive sympathetic activity can cause vasoconstriction. For completion here, I've added hematocrit and hence viscosity. So this will also influence cerebrovascular resistance and therefore flow. So some applied pharmacology. Generally, IV anaesthetic and analgesic agents will have a parallel reduction in cerebral blood flow and cerebral metabolic rate if there is intact flow-metabolic coupling. And so with that parallel reduction, there's no adverse effect on ICP. The exception to this is ketamine, and that's why historically ketamine was avoided in traumatic brain injury and was controversial. It's now, however, really well established that it's safe in trauma, as the pros of its use outweigh the cons. Opioids generally have minimal effect on cerebral blood flow and cerebral metabolic rate. This is in contrast to volatile agents. So all modern volatile anaesthetic agents will suppress metabolic rate. However, volatiles possess intrinsic cerebral vasodilatory activity as a result of the direct effects on vascular smooth muscle. So the net effect of volatiles on blood flow is a balance between reduction in flow as a result of reduced CMR and augmentation of flow as a result of vasodilatation because of vascular smooth muscle effects. So at a MAC of 0.5, metabolic rate suppression induced reduction in flow predominates. At a MAC, they're in balance and cerebral blood flow is unchanged. Beyond a MAC, the vasodilatory effects predominate, so cerebral blood flow increases even though cerebral metabolic rate is reduced. And then at really large doses, autoregulation is lost. Not all volatiles are the same, so sevoflurane causes the least vasodilatation and desflurane, if you have access to it, the most. In high doses, so well over a MAC, as I've said, there's loss of autoregulation. So this is why large doses of volatile or high concentrations of volatile delivered intraoperatively to achieve blood pressure lowering or burst suppression, if required, is a bad idea. And other methods and other drugs are preferable. So back to our craniotomy. We'll run through the key points of the pre- and intraoperative management. As well as your usual preoperative anaesthetic assessment, there are a few additional things to specifically consider. I think it's helpful to know what symptoms the patient presented with and currently has. Some signs and symptoms may well have reduced if the patient's been put on high-dose steroids. So make a note of any deficits or focal neurology and ask about signs and symptoms of raised intracranial pressure. Also ask about seizures. This is going to help you when you're handing over in recovery and assessing the patient post-extubation. Many patients will have been put on steroids or anti-seizure medication, so it's important to note whether these have been taken on the morning prior to surgery. It's worth reviewing the imaging and briefing with the surgeon about the likely tumour type, its vascularity and its position, in particular its position relevant to important structures like dural venous sinuses. This will influence chance of complications like significant blood loss, VAE and possible neurological deficits. Lastly, positioning. It's important to discuss the surgical approach and patient positioning at your brief, as this will influence where you choose to place your lines, as well as what table and kit needs to be prepared. Most common positions will be supine, lateral, or various positions in between these with varying degrees of head rotation. So, intraoperative management. General anaesthesia should be induced in a manner which results in minimal changes in cerebral perfusion and cerebral blood flow. So a very stable induction, maintaining mean blood pressure and avoiding hypercarbia and hypoxemia needs to be aimed for. This can be significantly helped by placing an arterial line pre-induction. There are many ways a stable induction can be achieved, but the most standard is a slow and controlled infusion with propofol alongside an opioid, typically a high-dose remifentanil infusion. Boluses of remi and or pre-induction doses of fentanyl will prevent the sympathetic response to laryngoscopy. And alongside this, a metaraminol infusion is used to maintain that blood pressure. Adequate time should be allowed for muscle relaxant to work before intubation is attempted, stating the obvious there. Armoured endotracheal tubes have advantages in neuro as they reduce the risk of kinking when the patient's head's manipulated and moved, and it's really important to be meticulous when positioning and securing this tube, and we'll be going through some tips for this as well as protecting the eyes in a practical session as part of this course. So consider the position of your IV access. Typically at least one large bore peripheral cannula will be needed. Weigh up the pros and cons of placing that good cannula in a place you'll be able to see and access it, such as the saphenous vein at the ankle. The goals of maintenance of general anaesthesia are to maintain ideal intracerebral hemodynamics, facilitate surgical exposure, facilitate neurophysiological monitoring if it's being used, although that's very infrequent in Plymouth, and also to provide neuroprotection and allow for a quick wake-up and neurological recovery. So with this in mind, at our institution, we typically maintain anaesthesia with a propofol infusion alongside remi. However, volatile anaesthetic can be used, and in other centres this is used as a standard. Positioning. So positioning and registration with a cranial-navigation system, if it's being used, the prepping and draping will all take a long time, typically at least 30 to 60 minutes, sometimes longer. And this is before a needle or a scalpel has got anywhere near the patient. Most of this is pretty unstimulating, but a key step which the anaesthetist needs to anticipate and proactively manage is when the surgeon pins the skull in a clamp. So they use this device here at the top right, a Mayfield skull clamp with 3 scalp pins. Putting that on is pretty stimulating. So to prevent a rise in blood pressure, a preemptive bolus of either propofol and or remifentanil is required. I choose one based on their current physiology, which in my hands usually tends to be propofol if I've already got a high-dose remifentanil infusion running and the patient's heart rate's on the slower side, but it doesn't matter. Positioning is led by the surgeon, as poor positioning can make the procedure difficult or even impossible. They need to position the head so that they can access the tumour, but also to optimise venous drainage. Too much neck rotation, for instance, can put pressure over the internal jugular and cause partial obstruction to venous outflow, which we obviously want to avoid. The eyes need to be protected during prepping to prevent any cleaning solution getting into the eyes. And then the sort of next physiological change to anticipate occurs when the surgeons infiltrate local anaesthetic with adrenaline. So they put this in the scalp where they're going to make their incision with the aim of vasoconstricting to help with scalp bleeding. And if you look at this and pay attention, you'll routinely notice a drop in blood pressure about 2 to 3 minutes after infiltration of typically 10 to 20 millimetres of mercury. This tends to resolve after a couple of minutes and is due to the beta-2 mediated effect of adrenaline in the local. So it sounds paradoxical, but we know that higher doses of adrenaline will cause alpha-mediated vasoconstriction and hypertension, but at lower doses, such as 1 in 200,000, which is used here, the beta-2 effects predominate. So have a look for this during your next case. In addition to antibiotics, there are several other intraoperative drugs that need considering, and these should be discussed with the surgeon at the brief. Steroids, typically high-dose dexamethasone, is useful to help reduce cerebral edema surrounding tumours. It's less effective for global edema. Seizure prophylaxis, typically levetiracetam, is given in certain patients at risk, such as those with frontal and temporal tumours. They may have already taken their dose that day. And thirdly, osmotherapy. There isn't strong evidence to support the use of one agent or the other, but at Plymouth we typically use hypertonic saline, starting with 2 mL per kilo of 5% sodium chloride titrated to effect. Historically we used mannitol, 0.5 milligram per kilogram, but we have found that hypertonic is easier to give, safer, longer lasting and more titratable. So both these agents, both mannitol and hypertonic saline, work by promoting neuronal dehydration, which in turn reduces brain volume. It also dehydrates endothelium, so reduces capillary wall thickness and reduces the distance for oxygen diffusion. Third effect is they both reduce blood viscosity as they draw that water into the vascular space, so they facilitate flow and oxygen delivery to the brain. And we'll discuss this in more detail later. So, physiological parameters to aim for during surgery include normotension. This is clearly, what this means is clearly slightly contentious and will depend very much on the patient. Being at the lower end of normal for the patient may help improve the surgical field, but cerebral perfusion pressure needs to be tightly maintained. The surgeon may ask for the blood pressure to be brought up slightly towards the end to help assess hemostasis before closure. Normothermia. Neurosurgical patients typically cool down quite a bit before the start due to that long prepping time and long exposure. But it's also very easy to overheat them during long procedures as they're fully covered. So place a temperature probe and turn off active warming once the temperatures hit normal range. We're now going to consider brain relaxation and intracranial pressure, their evaluation and their management. So we'll start with ICP. So intracranial pressure will be very familiar to you. This is the pressure within the closed skull, and it can be objectively measured by a range of devices. So your bolts or your EVDs. The Monro-Kelly doctrine describes the relationship between pressure and volume in this closed compartment. A volume change caused by an additional mass, such as tumour or blood, can be initially buffered by displacement of blood or CSF. But beyond a fairly small volume, around 100 mL, buffering is exhausted and cerebral ischemia and herniation will follow. Once the skull and the dura are open during a craniotomy, the term ICP isn't used. This fixed box concept doesn't exist, and intracranial pressure decreases to atmospheric level. So the term brain relaxation is now used to describe the size and firmness of the brain. Brain relaxation is determined by the relationship between the volume of intracranial contents and the capacity of the intracranial space. So it's a concept related to but distinct from intracranial pressure. The status of brain relaxation is important to us and the surgeons because it's relevant to operating conditions. So how well the surgeon can access what they're trying to reach. It's also relevant to retraction injury, so how much pushing and pulling of brain out the way happens. And it's likely relevant to patient outcomes. Unlike ICP, which is a number, brain relaxation is a more subjective assessment. So after the skull and dura have been opened, the surgeon will assess by sight and feel how tight or relaxed the brain is. When you're in theatre, make sure you go and have a look yourself and have a chat to the surgeon. So if the surgeon's opened the dura and the brain is perceived to be tight, there should be communication of that with the anaesthetist so that various manoeuvres can be undertaken to relax the brain, to improve operating conditions and protect the brain from retraction injury and ischemia. So what do we need to consider? The incidence of poor intraoperative brain relaxation is variably reported. It's more likely in patients with a preoperative raised ICP. It's more likely in patients with big tumours. The primary cause of a tight brain is an excessive volume of intracranial contents. So this may include your tumour, may include excessive CSF or excessive cerebral blood volume. And there are things that we can manipulate as anaesthetists. So up there, top right corner, 3 things. We can manipulate the cerebral blood volume to some extent. We can manipulate cerebral parenchymal free water. We may be able to manipulate local edema around masses. So it's worth having a think about which parameters to check at this stage. Do you have good control of physiology? Is your blood pressure and PaCO2 optimal? So take a blood gas as the arterial alveolar gradient may have changed. Adequate analgesia and anaesthesia will mean that CMR is minimised, so oxygen and glucose demand is low. Only in extreme and emergency scenarios will there be a role for burst suppression. Review the patient's position. Position has an impact on venous drainage and may be contributing to raised intracranial blood volume. And lastly, CSF. So CSF drainage is only really used for posterior fossa surgery, where space is at even more of a premium. Here an EVD may have been placed pre-procedure, or a lumbar drain may be placed after induction as part of the procedure. So what actions can you take? There is significant overlap between the management of the tight brain during intracranial surgery and intracranial hypertension, which you'll see and manage in the emergency department and the intensive care unit. The main difference is that you'll be in an operating theatre environment with an open skull, and you and the surgeon will be looking at the brain and objectively assessing it. So interventions aim to reduce volume of both blood within the cranium and parenchymal free water, so dehydrating brain tissue. And with every intervention, there are cons as well as pros. Firstly, ventilation. So keeping CO2 tightly at the lower end of normal range will be helpful, as we've discussed. Surgeons can tell if you let the CO2 rise. One could hyperventilate below a PaCO2 of 4.6 for a very brief period of time, but this is generally not recommended other than for emergencies because of its potential to cause ischemia attributable to vasoconstriction. So this should be used as a rescue measure only. Secondly, osmotherapy. As we said earlier, hypertonic saline and mannitol both promote neuronal and endothelial dehydration, so promoting a reduction in brain volume and promoting oxygen diffusion. A preemptive dose prior to dural opening may have already been given, but there may be room for more. So compare your serum sodium on your starting blood gas with your post-first dose of hypertonic gas and consider giving a second, perhaps lower dose. You do not want the sodium to rise above 155. There are risks with the use of both mannitol and hypertonic saline, namely cardiovascular complications due to fluid shifts into the vascular compartment. So both may precipitate pulmonary edema in patients with heart failure. Both may cause electrolyte disturbance. Hypertonic saline can cause hyponatremia and hyperchloremic acidemia. And both may cause extravasation injury if they're in a poorly positioned cannula. There's also a theoretical risk of central pontine myelinosis with hypertonic saline if given to a patient with hyponatremia. So your anaesthetic agent, it may be worth switching to a TEVA anaesthetic if volatile is being used, as that may help with cerebral vasoconstriction. Next, steroids. These will only help with peritumoral edema and won't act that quickly, so there's probably not a great role for them as a rescue technique, but ensure they've been given. And then lastly, positioning. Positioning might be hard to improve on if surgery is already underway, but perhaps a bit more reverse Trendelenburg or a bit more head-up tilt might be tolerated. You don't want the patient hanging in pins, but also bear in mind that this may increase the risk of venous air embolism and pneumocephalus and might require preemptive blood pressure management. So it might be there's very little we can do, and that resecting the tumour is the only thing that will help. So back to our craniotomy. It's the end of the procedure. Analgesia. Craniotomy surgery is not generally particularly painful, but patients might be more sore if a lower incision is used, if muscles have been divided, or if it's revision surgery. So a longer acting opioid is needed prior to turning off the remifentanil and waking up. Blood pressure augmentation with labetalol or hydralazine may also be required at or after extubation as the remifentanil comes off to avoid a blood pressure spike. I tend to give recovery a maximal blood pressure level I'm happy with and will aggressively treat hypertension in the immediate post-op period. Lastly, the surgeon needs to know whether the patient has any gross deficits following their surgery. So we need to be able to rapidly assess the patient's neurology. We should ideally know that a patient is obeying commands and moving all limbs prior to taking the endotracheal tube out, and certainly before taking the patient to recovery. As if there's concern about new deficits, an immediate CT brain may be needed. So that's all, a rapid run through anaesthesia for craniotomy surgery. Thank you for listening.